Good afternoon, and thank you everyone for joining me today for another Leadership Dialogue session. I'm John Hoppert, President and CEO of Grady Health System and Board Chair of the American Hospital Association. I'm very much looking forward to our conversation today as we talk about one of the most pressing issues in healthcare today. And of course, that is the sustainability and evolution of our healthcare workforce. When I speak with colleagues from around the country, workforce continues to be on their top priorities. And increasingly, health systems are looking for innovative partnerships to help make an impact on their own local pipeline. At Grady, we are working to build a stronger, more robust workforce for the future through a partnership with Georgia State University to expand the nursing education pipeline in Atlanta. It occurred to us during the midst of the pandemic that the nursing program at Georgia State University was lacking sufficient clinical sites in which to place their Bachelor of Science in Nursing students. And so we got together with Georgia State and developed a plan whereby we would become the exclusive training site for their students. And by doing so, we were able to increase their annual enrollment in the BSN program from 80 per year to 250 per year. We also were able to raise funds from a private philanthropic group in order to build out an education center and simulation center here at Grady for that program. So needless to say, I'm eager to hear what others are doing in this regard as well. You may have noticed that our format today is slightly different, and I am joined by our guest and more than usual. I'm excited as I think this will be a great dialogue about what makes some of these innovative partnerships that we are seeing develop between health systems, universities, and schools of medicine or schools of nursing so successful and impactful in addressing the current nursing and clinician shortages we are facing. With that, let me introduce our guests today, who are going to share some insights on what has made their partnership so successful. First, I'm pleased to be joined by Terry Poe, the Chief Nursing Officer at the University of Alabama Medical Center in Birmingham. We also have with us Dr. Maria Shirey, Dean of the School of Nursing at the University of Alabama, and Shirey and Polancich, Associate Professor of Clinical Innovation at the UAB School of Nursing. Thank you all for joining me. As we jump into our discussion, I will try to direct my questions, but I certainly encourage any of you who want to weigh in to do so. So let's start with Terry. I'm going to start with you, and I will ask that you give us a bit of background on how this partnership began. I understand it has been in place for a number of years, but share with us how it developed from the health system perspective.
Yes, thank you for the opportunity. The partnership was actually in place when I assumed the Chief Nursing Officer role in November of 2013. At that time, I was a recent graduate from the DNP program, so I think it helped a bit that I had been recently immersed in the program of the partners that I was coming to work with. Oddly, my first day of the interim role was a previously scheduled nursing partnership meeting. We established that day the need to make the partnership a priority. Over the next few months, with the goal of strengthening the partnership, we established a group of leaders from the hospital and the School of Nursing who could help move the partnership to the next level. Our goal at that time was to leverage our resources to provide outstanding patient care, invest in teaching and training for our interprofessional collaboration, and partner in research and scholarship. We developed a common mission, vision, values, and when people would think UAB nursing, our goal was for them to think about the entire nursing body across our campus, not just the School of Nursing or the hospital, but us inclusively. And then I think one thing that we don't talk about enough, even here, is that because we're a magnet organization, years ago we set a nursing leadership goal for our leaders at UAB Hospital to be minimally master's prepared. So when you think about it, we sent 40 or 50 nurses back to our own partners' programs in order to go through the master's, and now many through the doctoral program. And if you stop and think about the relationships with our School of Nursing partners that our own leaders now have as being part of that program, I think that has driven a lot of the work that we have done here together.
Well, that's fantastic. So tell me a little bit more about how that has evolved since you've been in that role.
Well, I think really, and my colleagues will talk about this, I'm sure, but a few years into our partnership, we developed the role that Dr. Polancich is in now. And I honestly think that's been the secret sauce behind what we've been able to do as a group. Our priority areas for the partnership we established should match the pillars of UAB medicine. And I think we spent a lot of time kind of drawing our model and how we were going to present ourselves as a partnership. But where we landed was not reinventing the wheel, but adopting what we were calling at that time UAB Medicine AMC 21, which stood for Academic Medical Center of the 21st Century. And they had a strategic plan. And so we aligned ourselves with the four legs of that plan, and it was engagement, quality, finance, and advancement of knowledge. And everything that we did as a partnership would line into those particular categories. And Shay helped us develop a strategic plan that was nursing focused, which followed those pillars of our organization. Well, not only did we strategically align in quality patient projects, which of course were very important in a hospital environment, we worked together to produce nurses who would know how to deliver the best quality care, and that would be innovative in models, and this would enable our nursing faculty to be more deeply engaged in clinically based research. And I have to say, one of the best examples of the partnership, and I'll end with this, is this occurred in the pandemic, when the pandemic was at its peak, and it was right at the end of the year, in the first year of the pandemic, and we were struggling as an organization. We did not have staff. We had complex patients that really needed care. For multiple reasons that many experienced across the country, we did not have the staff that we needed. And over a weekend, we brainstormed with our School of Nursing partners about how not only the faculty, but the students could come into the hospital environment and help us. And we built a model that would allow us quickly to hire students and faculty and have them show up as a team, which was amazing because the students came in as a partner with their faculty member. They had a true collaborative relationship, and they picked up thousands of hours over a Christmas holiday, the month that was a semester break. And I honestly don't know what we would have done without them. So I think the message was that now, strategically, when we want to talk about staffing, the first move we make is to contact our partners at the School of Nursing.
That's good. That's great. So, Dr. Shirey, in learning a little bit about this partnership, I saw the goals outlined as both strengthening nursing education, but also improving health across the region and state. Can you share with us how you have met those goals?
Yes, absolutely. From the standpoint of strengthening the nursing workforce, we have made growing the workforce a priority. And in order to do that, we need to have a good understanding of what the needs of the health system and the community are. And working with our partners and identifying those needs, we've been able to create programs that are responsive to those needs. So, for example, and I'll give you just a few examples of many, when there was a need to build the perioperative workforce, we created a corollary perioperative program that prepared students to be able to work in those areas. Transitional care coordination has been another area of priority, and we have built programs along those lines. Similarly, there has been a need for nurse anesthesia personnel, and so we have enlarged our class sizes to be able to accommodate those numbers that are crucial to meet the workforce needs of the health system and the community. Additionally, as Terry had mentioned, we have a very close working relationship where we communicate issues as they're developing. And certainly the COVID pandemic was one that brought us to the fore, innovating in ways that perhaps we wouldn't have thought of, but we were creating as we were working with the pandemic, and what she discussed in terms of the mobilization of faculty and students to work together in meeting the healthcare needs was remarkable, in the sense that not only were we able to contribute to approximately 30% of the staffing in the health system at that time, but also position the students and faculty to be true and significant contributors to the team and healthcare. And an example of that was training our faculty and students to be part of the proning teams that were so labor intensive in the critical care units. And having those teams there provided some support and respite for our own nurses working in the front lines needing that level of support. The beauty about this partnership is that we are never unwilling to discuss possibilities. And in contrast to saying no to a scenario, our response is what if and why not? And how can we make it happen? And it goes both ways for the School of Nursing and also the health system. Another thing along the strengthening nursing education has been our ability to align student projects with the strategic needs of the healthcare system, so that the students get an excellent experience, that they're supported by not only our faculty, but also personnel at the health system. And the students and our colleagues at the healthcare system are working on projects that are meaningful and projects that need to be addressed, and that there's expertise to be able to do so. And when Terry talked about the importance of Shay, who, by the way, has a faculty appointment at the school, but she works 80% of her time within the health system and 20% within the school. She's the liaison person with everything that has to do with the nursing partnership. She is able to work very closely with Terry to then come back to the school and identify, these are the priorities. How do we pair students with the best possible mentors and experiences? So that's a little summary on the nursing education piece. And then the other priority goal of the partnership is improving health across the region and the state. And primarily, the biggest area in which we've been able to do that has been through our nurse managed clinics for underserved populations. And I'll talk about two. One of them is our heart failure clinic, and then the other one is the PATH clinic for diabetes patients. And what these clinics have done, which were initially grant funded and now are funded and supported by the health system, is to be able to provide care for a population that normally would not have access to ongoing care and would generally show up in the emergency department for an unnecessary visit, but they were there because they had no alternative course of care. And so through the clinics, we're able to provide ongoing care, so that if the patients indeed need to end up in the emergency department or hospitalized, it's not at the rates that we had previously. So it's more cost effective. It's improved patient outcomes. It has improved patient experience. And from the standpoint of the clinicians working within these clinics, they're really satisfied with how they're able to provide care to meet an important need that addresses health equity of patients in our region.
It's really great to hear that you have both goals established and that you've made headway on both sides of that, because so often, particularly those of us who work in academic healthcare, we can sometimes be a bit focused on the academic side and not so aware of how what we're doing is impacting the health of the communities we serve. And I really find it admirable that you all have been able to do both and to balance both. So Shay, your turn. It is clear that a strategic academic health system partnership can result in innovations beyond simply bolstering the pipeline. So can you tell us any specific successes you've experienced, innovations, clinical applications, or enhanced quality outcomes that have come from this?
Yes, really, thank you for the opportunity. Well, we redesigned our academic practice partnership really around 2016. We realized that we had great opportunities for clinical innovation, specifically with improvement, because we had a lot of expertise in this area. In the last 7 years, we have done a lot of work to focus our partnership functions and really our tactics on activities that improve care for our patients and to promote value for our health system. From a clinical perspective, we strategically focused on improving an opportunity for the health system as partners. We selected hospital-acquired pressure injury, and we initiated that through really an academic practice partnership, clinical nurse leader pilot in 2016. Our happy numbers of all stage were far above what we wanted as an organization, and we embarked on what is now a 7-year journey to improve our outcomes. We use both the expertise of our academic partners for the research and evidence for practice, and then of the clinical teams, we use the clinical expertise of our UAB medicine nursing staff. Following a series of iterative improvements and PDSA cycles, Plan, Do, Study, Act cycles, and improvement research, we've seen a sustained decline in our all-stage hospital-acquired pressure injuries of 40% or greater per year, and a greater than 80, sometimes 90% decrease from our baseline to our lowest month of 11. This is a 1,200 bed hospital, 11. So that was a major improvement. And in addition to our focus project area, we have modified our process for, as Dr. Shirey was saying, our DNP student, their project development and their placement. We realized early that we could strengthen our student project outcomes by placing them in these priority areas using our learning health system lens. So we've created a menu of student projects that Terry, myself, and one of our assistant deans in the School of Nursing, we meet regularly and monthly, and we allow our students to identify projects that not only meet their interests, but that are within our health system goals. And then as we strategically place students into these projects, we assign clinical mentors to help remove the barriers. We've also, out of necessity, created a secure health system data process. We've instituted a systematic process for providing evaluation data that's not always available to our student, and it's also approved by our privacy and security teams. In the last 3 years, we have completed 73 DNP projects with health system focus. So that's a really great number of focus projects. And currently, last but not least, we're focusing on the nursing workforce. We've implemented 2 pilot projects that are designed really to strengthen our workforce. We have a dedicated education unit where we're focusing on retention of the experienced nurse at the bedside, really hiring those master's prepared nurse to stay at the bedside, be that clinical expert, and be that clinical teacher. And we've also created what we're calling a care-based model pilot, where we're evaluating a different model of care using team steps and delegation training, and having our RN, LPN, PCT triad practice to top the scope. So we are one of the few really hospitals that have a formal study for evaluation with this pilot on missed care. So those are a few of our innovations.
Well, thank you, Shay, because one of my follow-up questions you've answered, and that was going to be, what have you all done around looking at actual bedside care redesign? and I'm really pleased that you shared with us that what you're doing. You know, the American Hospital Association has a task force on workforce, and of course, nursing is highly integrated into that with AONL. And the next chapter in their work is to really take a deep dive into bedside care redesign or potential for model redesign to help each profession work at the top of their license, but maybe even introduce new roles we've not imagined into the picture so that nurses can provide nursing care. Because I don't have to tell the three of you, we've offloaded so much unnecessary work on nurses that it's oftentimes made the work unsatisfying. And I think the pandemic showed us that nurses who choose to be at the bedside want to do nursing care, not everything else. So I have a follow-up question, and this is for anyone who wants to answer it or everybody. But it really is looking at our total field of hospitals. Not all have these types of strategic partnerships, and some may be looking to do that and to build such a partnership. So where would you recommend they start? And are there any challenges you would tell other health systems to look out for?
I can start with my experience, and then I'll let Dr. Shirey and Dr. Poe finish up. We've always had an academic practice partnership really for placing students, but our redesigned partnership structure and function created a pathway for us for unexpected and positive growth. We continue to break down any silos, really territorial kind of domains from academic versus practice, and created the pathway for collaboration that we had not experienced previously. The process, in my opinion, has to begin with a strategic plan and a formal evaluation plan. I think you need both. One is your roadmap and one is your compass. I think it's imperative that you know what you want to achieve and that you can measure those outcomes and your return on investment. Our initial challenges when I started working in this were around communication. It really takes blunt and honest communication and flexibility. There may not always be the win-win, but you always probably have positives. So it also takes commitment and resources, and I think you have to have all of those.
So I would add to that to have a successful partnership like what we've been able to have, you need to have a spirit of ongoing improvement, a sense of inquiry and commitment to each other. And the way we started this was with a formal memorandum of understanding that specified what our responsibilities to each other would be, what were the guiding principles of our relationship, and really focus on staying true to that work. I can pick up the phone at any hour of the day and call Terry with a concern, and she can do the same with me. And we're open to possibilities. You won't hear from us, no, we can't do that. We've done that before, it didn't work. We're always open to the possibility of what we can do to really address the focus of our mission, and that is to provide the highest quality patient care possible within the context of an academic health system. And we recognize that each has strengths and resources, and we bring them together because together we are stronger than we would be if we were working as independent units.
I think just to echo all of that, I think from a CNO standpoint, you think as a CNO that you know how to move a process forward. I think for me, what I realized is that with our school of nursing partners, and this is really back to the study, the CNL program that Shay was talking about, what I realized is that what Shay brought to the table for me was an opportunity to kind of slow down and listen to the evidence. And she came forward with that I did not have. I mean, I was trying to move a mark because our chief executive officer wanted it moved. And I jumped in trying to communicate how to fix something that I didn't really even understand where was broken. And I think one of the first things I remember about the meeting with the CNL students and how we're going to make a difference is that I jumped into trying to fix the process at the first thing that was broken, and Shay stopped me, said, be patient, let's draw out this whole process before we start fixing anything. And that really is what generated the change. So I think it's a great example, and bring your expertise to the table, but yield to those that have expertise in other areas, and together you come up with some pretty great outcomes.
That's fantastic. I really appreciate that comment. Those of us, and I'll speak for myself, who have been at this a while, we love the fixing, right? And sometimes we don't back up and look at how to go about it the right way. So I appreciate that. Well, I really want to thank all three of you for joining me today. I appreciate you sharing the great work you're doing at the University of Alabama in Birmingham. And I encourage all of our viewers to explore the workforce resources available through the AHA and through the American Organization of Nurse Leaders as you consider your own workforce strategies and partnerships. I would encourage you to utilize the amazing amount of content and information that is available around workforce that has been developed over the last years that is on the AHA website. So until next time, thank you to everyone for joining us today. I hope you'll be back for next month's Leadership Dialogue. Thank you very much.